This is Professor Maha Shahin from Mansoura University. Today's lecture is about diabetic retinopathy. Diabetes is a major health problem in Egypt. Egypt has the ninth largest population of diabetics worldwide. In 2007, the number of diabetics in Egypt was 4.4 million, in addition to another 2.2 million with prediabetes. In 2017, the number of diabetics in Egypt was 8.2 million, which equal to almost 15% of adult population in Egypt. The number is expected to reach 13.1 million by 2035. Diabetes affects almost every tissue in the eye. It affects the cornea, leading to dry eye. It affects the pupil, making dilatation of the pupil is very difficult. It affects the optic nerve, causing diabetic papillopathy. It leads to the formation of complicated cataracts, in addition to diabetic retinopathy and diabetic maculopathy. In the United States, 30% of the American diabetic population over the age of 40 will suffer from diabetic retinopathy. 24,000 new cases of blindness in the US each year is caused by diabetic maculopathy. This is a growing issue. Diabetic retinopathy is the leading cause of blindness in the working age adult group ranging from 20 to 74. By 2016, US had 7.7 million of diabetics suffering from diabetic retinopathy. This number is expected to reach 11 million by 2030 and 14.5 million by 2050. What are risk factors for development of diabetic retinopathy? Some risk factors have been identified while others haven't. High lipid profile, hormones of pregnancy, hormones at puberty, association with nephropathy, obesity, and nutrition, among others, are among the list of risk factors for diabetic retinopathy. The two most important risk factors are duration of diabetes and control of diabetes. Hemoglobin A1C, glycosylated hemoglobin, is used for assessment of control of diabetes mellitus. Hemoglobin A1C should be below 7%. Hemoglobin A1C is done every 3 months to assess the control in the preceding 3 months. Diabetic retinopathy and kidney diseases are closely associated with age and metabolic and cardiovascular risk factors. Retinopathy can predict chronic kidney disease development. Patients with chronic kidney disease are at high risk for diabetic retinopathy. Association between albuminuria and retinopathy in diabetics have been well documented. The occurrence and progression of diabetic macroangiopathy represent a wide individual variability. Macroangiopathy may occur soon after clinical onset of diabetes in patients with fairly good metabolic control and with mild form of the disease. On the other hand, in some patients with an average unsatisfactory control, late complication may not be recognizable even a few decades after diagnosis. A genetic element was investigated with some genes to be accused of causing this discrepancy. What causes diabetic retinopathy? The two main factors in the pathogenesis of diabetic retinopathy are leakage and occlusion. Leakage is caused by loss of pericyte from the wall of the small blood vessel. The normal ratio of pericytes to endothelial cells is 1:1. With loss of this ratio, this will lead to leakage of the fluid out from the blood vessels. What causes the occlusion? Basement membrane thickening, endothelial cell damage, RBCs changes, and increased thickness of the platelet. Leakage will lead to edema. Then exudate is seen at the edge of oedematous and non-oedematous retina. So, hard exudate is seen mainly in cases of focal maculopathy. Occlusion will lead to ischemia with subsequent formation AV shunt, IRMA, intraretinal macrovascular abnormality, and the release of vasoformative substance from the ischemic retina. The most important one of them nowadays is the vascular endothelial growth factor. This will lead to the formation of new vessels at the retina, causing proliferative retinopathy, and rubeosis iridis at the iris, leading to new vascular glaucoma. This figure shows the location of lesions in non-proliferative diabetic retinopathy. Flame-shaped hemorrhage is seen in the superficial layers of the retina. Dot and blot hemorrhage are seen in deeper layers. Cystoid macular edema also is seen in deeper layers. Edema is seen in the outer plexiform layer of fringes, and hard exudate is seen just next to it. Not all cases of diabetic maculopathy is in need of treatment. For example, cases of macular ischemia are not treated, unfortunately. Early cases of diabetic macular edema can be controlled by just controlling the systemic factor, namely control of diabetes, control of hypertension, and control of hyperlipidemia are enough to control early cases of diabetic macular edema. Tedros has identified the cases that are needed to be treated in diabetic macular edema. They call them the clinically significant macular edema. How to identify clinically significant macular edema? It's either one of those three conditions. Either retinal edema within 500 microns from the center of the fovea, or hard exudate associated with adjacent macular edema, and the third case is macular edema of 1500 microns. Any part of which is within 1500 microns, that's to say, one disc diameter from the center of the fovea. Meaning that in all cases of clinical significant macular edema, you should have thickness, you should have edema, not just hemorrhage or exudate. This is the case of non-proliferative diabetic retinopathy. We can see hard exudate, we can see microaneurysm, we can see soft exudate or cotton wool spot, which indicate microinfarction of the superficial layer of the nerve fiber layer. We can see dots and blots of hemorrhage. You cannot differentiate between dots of hemorrhage and microaneurysm unless with the use of fluorescein angiography. This is new vessels. When new vessels at the disc, this is NVD, new vessels at the disc, and when this in any other part of the retina, this is NVE, new vessels elsewhere. New vessels are immature vessels, and these immature vessels will leak blood, leading to the formation of pre-retinal hemorrhage, vitreous hemorrhage, with sudden diminution of vision in those patients. Then new vessels will undergo fibrous metaplasia, leading to the formation of fibrovascular proliferation. And then, with the contraction of the fibrous element, this will lead to tractional retinal detachment. In cases of diabetic macular edema, this photo illustrates the complaint of this patient with haziness and sometimes irregular scotoma. What are the investigations of diabetic retinopathy? First, you have to investigate the systemic factors. Never to forget investigating hemoglobin A1C, blood pressure, and lipid profile. Then investigate the eye. What is the indication of fluorescein angiography and what is the indication of the OCT? Fluorescein angiography has to be done. Fluorescein angiography gives information about the superficial layer of the foveal avascular zone. However, OCT angiography gives more detailed information about the deeper layers. In cases of focal laser treatment, fluorescein angiography is used for localization of microaneurysm. This patient with diabetic retinopathy with tersnate exudate, if you look at the peak phase, you will see much more microaneurysm in the fluorescein angiography than those seen in the fundus photography. So, this photo or this shot in the peak phase should be projected during the laser treatment to guide the laser treatment. Fluorescein angiography helps to differentiate between IRMA and the new vessels. Sometimes, fundus photography or even red-free photography cannot differentiate between IRMA, intraretinal macrovascular abnormalities, or small tufts of intraretinal new vessels. However, fluorescein angiography can make this differentiation. In cases of IRMA, no or minimal leakage occurs, while new vessels will lead to marked leakage of the dye out of the new. Diabetic patients will have poorly dilatable pupils or sometimes diabetic cataract, sometimes opacified posterior capsule, or even the media is not clear after Riyad capsule. All these factors of hazy media make it difficult to identify small tufts of new vessels. Fluorescein angiography to identify small tufts of new vessels. The leakage can be clearly seen through this hazy media. So we have fluorescein angiography as a baseline before the treatment. OCT will help for localization and to determine the severity of the macular edema by assessment of the macular thickness. Lamellar macular hole may be missed in fluorescein angiography, but it's clearly seen in OCT. Serous retinal detachment is another pathology that can be easily missed in fluorescein angiography if associated with cystoid macular edema. The cystoid macular edema will mask the serous retinal detachment. Vitreomacular interface changes is clearly seen using OCT. OCT is used for the follow-up of the patient and to assess the response of the patient to the treatment. OCT angiography will help the treating ophthalmologist to identify deeper layer of the period. Patient with early diabetic retinopathy changes will have no complaint. Thus, screening for diabetic retinopathy is a very important tool for the management of diabetic retinopathy. Adults and children above 10 years of age should have examination within 5 years of the onset of type 1 diabetes. On the other hand, type 2 diabetics should have an initial dilated examination at the time of their diabetes diagnosis. What are the methods used for screening of diabetic retinopathy? The current standard methods are best-correct visual acuity and dilated fundus examination. Digital fundus color photos is more sensitive and more specific. However, plenty of patients are annoyed by the mydriasis, so they skip the annual examination. Non-magnetic photography provides more convenience to the patient, so more compliance of the patient, but it has more failure for detection. Fluorescein angiography is the best for screening of diabetic retinopathy, however, it's very costly. Laser treatment is a standard of care for diabetic maculopathy. The introduction of anti-VEGF treatment has made a revolution in diabetic macular edema treatment in the last decade. What is the plan for treatment of diabetic retinopathy patient? First of all patient has to control their systemic factors. Control the diabetes, control the hypertension, control the hyperlipidemia. Patient with no retinopathy scheduled for follow-up after 1 to 2 years. Patient with mild non-proliferative diabetic retinopathy with dry macula or non-clinically significant macular edema is scheduled for follow-up after 6 to 9 months. Patients with diabetic macular edema are classified into 2 groups. Those with non-centrally involving are treated by focal laser treatment. Those with centrally involving macular edema as seen by OCT, not by fluorescein angiography, by OCT, is treated by anti-VEGF treatment. They will receive 3 to 6 loading dose and then reassessed. Patient with good response will continue the treatment until stabilization of visual acuity and macular thickness as measured by the OCT. Those with poor response first shift to another drug of the anti-VEGF group. If no response to the other drug, then switch to corticosteroid. For patient with proliferative diabetic retinopathy, the main line of treatment, the first line of treatment is pan-retinal photocoagulation. Some protocol will adopt anti-VEGF for treatment for those patients, but it is very expensive, as those patients will need anti-VEGF treatment for life. If anti-VEGF is used for treatment of PGR, it will be used for life, which makes it a very expensive treatment even in the richest countries. What are the indications for pan-retinal photocoagulation as a treatment of PGR, proliferative diabetic retinopathy? The indications are high-risk criteria are new vessels at the disc more than 1/3 to 1/4 disc area, or less extensive NVD plus hemorrhage, or new vessels elsewhere more than half disc diameter in area in addition to hemorrhage. What are the parameters for laser pan-retinal photocoagulation? Initial treatment is 2,000 to 3,000 per. Spot size ranges from 200 to 500 micrometer and depends on the contact lens magnification. The aim is to have gentle intensity burn. Duration is usually 0.1 to 0.05. And this figure shows area that should be covered by complete pan-retinal photocoagulation, and follow-up is needed for 2 weeks. Good, efficient pan-retinal photocoagulation will lead to regression of new vessels with residual ghost or fibrous tissue and pale disc. Persistent new vascularization or persistent hemorrhage mean that this patient needs retreatment. Severe persistent vitreous hemorrhage, dense persistent premacular hemorrhage, retinal detachment involving the macula, in addition to failure to control the new vessels by laser treatment, are indication for vitreoretinal surgery. It's very, very important to differentiate diabetic retinopathy from hypertensive retinopathy, because most of the patients are diabetic and hypertensive. Changes occurring at the AV crossing and the presence of cotton wool spot mainly around the disc are highly suggestive of hypertensive retinopathy. Treatment of hypertensive retinopathy is just control of the blood pressure. Send your patient to his internist to control his blood pressure. So it's very crucial to differentiate diabetic retinopathy from hypertensive retinopathy to save your patient unnecessary laser or intravitreal injection. Thank you.